Hi, guys. I am Dr. Manisar, your host for evening from Dearborn, Michigan. A change of scenery, and yeah, we this is our first podcast in English. We have done this because to reach a diverse audience, so that we could help our message uh, get out to a wider audience. Today we have with us one of the most famous endocrinologists in Dearborn, Michigan, who is a clinical assistant professor at Wayne State University in endocrinology and is president and clinical director at Metro Detroit Endocrinology Center, Dr. Upada Al-Zuhaili. He graduated from Damascus University Faculty of Medicine and completed his residency from Wayne State University Hospital in 1998. Completed his fellowship in endocrinology, diabetes, and metabolism from Cleveland Clinic Foundation in 2000. Welcome, Dr. Al-Zuhaili, to Medcast.
Thank you very much. Thank you for having me.
Yeah, so it is an honor to have you here. So the topic which we are about to discuss today is a very important topic, is becoming very important in as our diets are changing and as the world is changing, which is diabetes. One of the most commonly seen diseases, whether it is primary care or your profession as you specialize in, which is endocrinology, which helps you to get a better perspective. So what do you have to say about diabetes in South Asia? Because most of our audience is from South Asia, and South Asians are there around the world. So what do you have to say about diabetes? And in more general, like, how does race play a part in how diabetes like pans out in a patient?
That's a great question. Unfortunately, diabetes type 2. I mean, we're talking type 2. Remember, this type 1 diabetes is an autoimmune antibody attacks the beta cell, causes the insulin deficiency. You have to be on insulin. We see increase in type 1 diabetes, but there's no ethnic or cultural or countries um, disparities. It's pretty much an equal opportunity disease. It can happen anywhere, any place. We see more of it because I think the more exposure to viruses and stimulants and chemicals and radiation, the more autoimmune disease we're going to have. We see more thyroid, pituitary, adrenal, and of course, type 1 diabetes. But what we're really talking about now is type 2 diabetes. Type 2 diabetes is the more common. We think used to be the habit on adults. We don't call them adult onset and young onset. I've seen type 1 new onset at age 60, and I've seen type 2 in 5 years old. A lot of children diabetes now is type 2 diabetes. And part of it is obesity, food habits, eating habits. Other than the habits we have that are significantly increasing the presence and the prevalence of type 2 diabetes and becomes more difficult to control, unfortunately, there's some cultural, ethnic, regional variation. If we look at distribution around the world, insulin resistant, definition of insulin resistance is poor disposal of glucose by the muscle. That leads to increased insulin secretion early in the process, and that leads to obesity, hypoglycemia, heart disease, cancer, and multiple other things that happen because of early insulin resistance. It looks like the insulin resistant type 2 diabetes incidence is probably, if you look at all over the world, in Pakistan, India, some parts of Bangladesh, is probably the most common. So, for example, somebody with BMI of 30 in Pakistan or India will carry much higher risk of diabetes and heart disease than somebody with a BMI of 30 in Japan, in Korea, a white person in Europe or United States. So if you look at distribution, like all over the world, I think the most insulin-resistant patients in the world are American Native Americans, what they used to call them Indians, but they are actually Native Americans. Native Americans tend to have much higher percentage of type 2 diabetes and much more insulin resistance. In a way, the prevalence of diabetes in the lifetime of Native American can be as high as 72%, comparing to 15-20% in the general population of the world. It is issue with the being in reservation, the food habits, eating habits, and certain thing that is happening with them. Outside that, the highest percentage of diabetes and heart disease, the whole metabolic syndrome that come with it, come from India, Pakistan. We see some of the Gulf countries after that. Hispanic will be after that. Some of the other Middle East countries, Northern African country. Then even in Europe, after that, even African American in the United States, for example, in Europe are less insulin resistant than the others. And then probably whites, and even in that distribution, there's also in Europe distribution. Like if you're coming from France, Italy, Spain, you're a lot healthier with the genes than somebody coming from Germany, England, or Eastern European countries. So there's a lot of variation in this. Why that's important, because we don't see that only based on eating habits, because we see the Indians who move from India or Pakistani move from Pakistan to United States, actually they get more diabetes. They don't even get better, they get worse. So it's really not about the eating habits and the local habit. I think there's a lot more into genetic factors, where distribution of central fat is different between different people. So if you have the same BMI, but the higher percentage of your fat is central fat. The fat is around the omentum, the pancreas, the heart, is becoming an endocrine order that produce a lot of hormones like and cytokines, and these can cause multiple issues of problem. Probably insulin resistance the most common of them, and everything that leads after that. The more genetic distribution of fat into central areas, the more risk you're going to have from these insulin resistance, unfortunately. Knowing that I come from this area, I come from the genetic areas that I'm higher risk of diabetes, that mean from day one, I have to work on preventing all of that. What are the things that I can do to prevent myself, my family, my friends, my neighborhood from becoming diabetic? If I know this is what's going to happen, if I can diagnose insulin resistance early, certain things you can do behavior-wise before we get to medication, it can prevent that from progressing from insulin resistance syndrome into type 2 diabetes.
Okay. Thank you so much for your detailed answer. A more common phenomena is like an very like complex topic surrounding diabetes is fasting or the month of Ramadan. And fasting is there in other religions as well, and some people do intermittent fasting as well. So, how can fasting affect diabetes, and like what care should be taken during fasting for diabetics, if you could shed some light on that.
So this is also a great topic. It probably led to the previous point that if I can prevent progression from pre-diabetes or insulin resistant to diabetes, then I have to have the power, the mental power, the physical power. I can control my activity, my eating habits to prevent that progression. And we notice that as people have hard time doing this, I tell you, people say, I'm sorry, I can't stop eating carb. I can't stop eating bread. And, our cultures in South Asia, just like me from the Middle East, we love bread. We love rice. Most of the things we like is carbohydrates. The more carbohydrate we have, the more insulin resistance we have, and the more problem we're going to have. Controlling your habits becomes a practice, is an exercise to try to see how can mentally change my habit so I will adopt a much better habit to prevent diseases. And people, when they say, I can't do this, can't do this, can't do this, what we see in Ramadan is something so beautiful, that people who can eat and drink and smoke and do whatever they want outside Ramadan, they come in Ramadan and they have just before sunrise to sunset. Well, even the halal food and water becomes unpermissible. It's haram. You can't drink it for it. So people find at that time, because they develop the habit when they're young not to eat or drink, it becomes easier for them. I know it's still hard with all of but they train themselves, and they feel very awkward if they have to break their fast because of sickness or something else. So what what Allah have given us the fasting and say لعلكم تتقون. So prescribe fasting upon you so you will fear Allah. تتقون then mean you start protecting the orders of Allah, because now you can see, okay, what is a good behavior and bad behavior, so I can avoid it. So you train yourself that is difficult to be trained to do the right thing. That training we think is going to be also great if we take it and use it for chronic diseases. A lot of people say, well, why Allah prescribe fasting, and is it difficult, unhealthy? And I had to convince a lot of my fellows American physician initially who came here that this is actually the healthier things, but if we use it right, because it's a training yourself to behave, and that behavior hopefully will help you get much better eating habits and habit that will prevent chronic diseases on the long run. That would help us on the long run to prevent these complications also come from diabetes and metabolic syndrome. The fasting that we have is different than fasting in other religions. Some they can go a day or two without eating. So they're not sure about how healthy it is. Some they stop eating a certain food. They will pick sweet. They will pick something greasy to stop eating. So there are different religious practices. We can't call them all the same, but we're talking about the fasting that Muslims do. It's very similar to the popular diet that is all over the world now. It's called the intermittent fasting. But you look at intermittent fasting, it looks almost very similar. You don't eat for like 16 hours, you eat in these 8 hours. But we look at all the data from intermittent fasting, it looks like people, diabetes, blood pressure, weight, everything gets better. If we look at published data on Ramadan, for example, fasting in Muslim countries, we have some positive results, but the majority of the results showing the opposite. Actually, Muslims in Ramadan tend to get more weight. Their diabetes, heart disease, and hypertension gets worse. Why is that? What is the discrepancy? If I'm doing the same thing in intermittent fasting and fasting in Ramadan, why I'm having good results here, bad results here? And I think the reason is also behavior. For example, what I believe in for example, the Middle Eastern culture, and I'm sure the same thing in Pakistan. When we don't eat, as soon as we come to Maghrib, we eat something, we pray Maghrib, and then we sit to eat. And it's like, we call it like, everything break loose. Now I have to eat everything on the table. In Ramadan, we don't take 1 or 2 items. It has to be 7, 8 items. And after 7, 8 items, and that includes bread and rice and carbohydrates and different food and meat, then becomes the sweet, then the tea, then the coffee, then the fruits, then it just nonstop eating. When the bodies eat all day and just load them with a lot of food at Maghrib time. That's why most of it after Maghrib and Ramadan, after iftar, when we sit like this, I can't breathe, I can't sit. We all have this phenomena of we always just want to lay down, we can't even move. And if we kind of go back what the Prophet Muhammad and Sallallahu Alaihi Wasallam in terms of like what is the advice to give us when we eat and break the fast is you eat a little bit, and then you pray salah, then you eat a little bit, then you go to tarawih, then you eat a little bit. So having smaller amount of food here and there, and having a little bit also to have suhoor. Why is that suhoor barakah? Because even have that suhoor becomes really important. So now you don't have long period with no food and 1 hour of lots and lots of food at the same time that the body cannot handle. That's the reason why these habits make the data on Ramadan very bad, and the good habits makes the data on Ramadan is going to be good. So if we use it correctly, fasting on the body is very healthy. If you can adjust your medication, you can fast. We tell people whatever medicine for type 2 diabetes you're on, you will have good results. You'll be able to fast. Of course, we're not talking about type 1 diabetes. Usually type 1 diabetes, the idea you don't fast. Type 2 diabetes, in general, we tell them you can fast unless you have heart disease or renal failure that stop you from doing this. But the majority of the time for type 2 diabetes, fasting is very healthy and it's very good for the results that we get with on diabetes. But we have to follow these habits and stay active, eat small amount here and there in between, still need to be on a low carb diet even in Ramadan. If we follow these rules, we will have better results, and we should have same healthy benefit that intermittent fasting do if we follow these habits. That takes a lot of cultural changes and cultural adaptation that happen because always there's social pressure. You have to have fasting in Ramadan, you have to have a group of people, there has to be a lot of food, and you have to eat everything. Unfortunately, these are the habit that makes it difficult for us to get healthy in Ramadan. Um, I hope that answered the question on the health benefit of Ramadan. I mean, we even outside diabetes and all of that here again, we have data after data that fasting, even the brain, is it areas in the time when you don't eat, we need this metabolism. We need this metabolism to be go into this fasting state and prandial state. Fasting state is a lot different metabolism, a lot of different hormones. Even the psychiatrists, psychologists tell you fasting is good for the psyche, for the brain. There's something called autophagy where the brain almost clean itself in fasted state. So there's so many benefit happen, and God created us a lot greater where we have these phases of fasting state where a lot of different hormones are produced, and a prandial state where a lot of these hormones are produced. Unfortunately, with abundance of food and the habits that we have and lack of activity, we are staying in this prandial state all the time outside Ramadan. And this prandial state is causing a lot of problem, chronic diseases. And then people ask why we have more diabetes, why we have more cancer, why we have this, why we have this. I'm seeing 5 and 6 years old, 10 years old who are like 100 pounds overweight. We've never seen numbers like this. I think part of it is food industry and what are we exposed to poisons of food, but also part of it to the habit that we have. So going backwards, the fasting can be very healthy for the body for chronic diseases unless there's a definite health contraindication for it. Unfortunately, our habits makes it difficult to benefit from it.
Thank you so much for such a detailed answer that would help answer our audience's questions. So I would want to ask you one other question that which is one myth about diabetes? Although I know there are many myths around diabetes, which is one myth which you wish people would have known and would make their lives easier?
Well, there's a lot of them, unfortunately. I mean, one of them, people said that, I got diabetes because of stress. I got diabetes because of eating sugars. I got diabetes because of a chemical I was exposed to certain ways and all of that here. You got diabetes because you genetically prone to diabetes. If your grandparents, anybody in your family have diabetes, you're prone to diabetes. If you know that, then you can actually behave early before you become diabetic to prevent it. But the idea that no, I'm fine, I don't wake up till I have diabetes. And another myth also, people think once you have diabetes, it's irreversible. It's like a death sentence. Oh, I got diabetes. Oh my God, now my eyes are gone, my kidneys are gone. They would cut my feet. That's what happened to my father or my auntie or somebody. And its cycle goes like this is almost a death sentence, there's no solution for it. If you got diabetes early in the process, you still can reverse it. If I can see you in the first 3 years of diabetes before we go on insulin, we have drugs, we have certain habits. We tell people exercise, build muscle, increase the muscle mass so you can burn more food, change your habit, don't eat at night, eat less carb. There's a big chance that you can reverse diabetes. Don't rely on a supplement here. A lot of people tell you that, oh, I heard if you take this olive oil from Indonesia, then you can cure diabetes. If you take this supplement or this rare plant from India, you cure diabetes. None of these things are true. You can reverse diabetes if you get in the first 3 years before you take an insulin by adjusting your habit, taking medicine to help your beta cell work better and stop it. So the idea that it is not reversible, it is reversible. It will get better. It will improve. It will be gone completely if you know what to do. Yeah, but the problem is sometimes we don't take care of diabetes or feel it's serious till too late. Now, my beta cells are gone. I'm on insulin. I have complication. My vision's not very good. Start getting ulcers in my feet. Now people wake up. It's like, oh, let me take care of diabetes. It's too late. The damage is done and nothing you can do. So the probably most important thing knows that type 2 diabetes is preventable. Type 2 diabetes is reversible. These are really important. If you know that, then you're willing to put the effort to prevent it or reverse it early in the process. But if you give up to it, then unfortunately you're looking for trouble. One lost organ after the other.
Yeah, for sure. So, one other thing, although I know that weight loss is a topic on its own, but in context of diabetes in the US, while working with you, I have seen that in the US, weight loss is taken very seriously here, and we often prescribe medications like phentermine and phentermine, Wegovy, Trulicity, all of that for weight loss. While they're like in developing countries, weight loss is left up to physical activity, although physical activity plays a huge role in weight loss. But how do you think that these drugs can help with weight loss and in turn with diabetes?
So it's unfortunately sad topic because you try the best you can, but sometimes your genetics and make you prone to weight gain. And this is a different topic. And again, probably need a whole different meeting by itself. There's a genetic clock for your weight. There's studies that looked at people that force eating and forced to lose weight, let go after a few months, they go back to exact same spot. So there's a genetic clock where your weight is going to be. So that means you always have to work hard to bring your weight down. And sometimes it's easy with activity and diet. Sometimes people do, and I believe them. It is not everything under the people behavior. Sometimes you do the best you can, but your genes will still catch up to you. And whatever you do, you still have problem with weight and lead to diseases in the future. So we have limited amount of drugs. Recently, we were using the GLP-1 injections, and these are replacing hormone in our body that makes us feel full and help us lose weight. Um, there's medication that will suppress the appetite, and despite the bad reputation for it, it has been there for 40, 50 years. Phentermine, for example, has been safe if you lose weight. The difference is you, in order to start taking weight seriously, we have to understand that weight is not a choice. Weight is not a easy to get rid of, and there's sometimes two people in the same family who one eats whatever they want and they don't gain weight, and somebody smells food and gain weight. So there's genetic factors. It's going to play a role. So blaming the person only for the weight has been a problem that doesn't get you anywhere. And a lot of, unfortunately, the doctors make that mistake. They always blame the patient. It's you. If you eat better, you lose weight. If you do this, if you do this. Of course, there's patients we don't do everything without, but there's a lot of patients who do everything correctly, but they're not successful. These are patients who have to coach them up and understand and figure out what kind of problem they have so we can solve it to make sure they lose weight. So the difference between here, finally, they start considering obesity, weight gain as a chronic disease, a condition. It's not a cosmetic issue, because it's not all about cosmetic. When you gain weight, especially insulin resistant, you get a heart attack, diabetes, hypertension, cancers are connected to weight. Cancer from obesity is 10 times more than cancer from smoking and asbestos combined. So they're really health risk with weight. So if we take weight seriously, consider it a chronic condition that we treat it, continue to treat it to prevent complication diseases, then we're successful. If we consider weight as a cosmetic issue, so I can do remove the fat from here, or and I dress up to look differently. We look at it, it just people look at me. You're not going anywhere with this. You're not benefiting. Also, if you think that this is an acute, I mean, some people look at a commercial and say, well, take this, you will lose 30 pounds in 30 days. And they go on this 500-calorie diet and then run a marathon. They lose 30 pounds in 30 days, and then they gain 40 pounds next month. That's not the right way to approach weight, because again, this is chronic condition. You have to approach it that change behavior, lose weight slowly, and continue to do it. There's nothing in the world, including surgeries for weight loss, that is permanent. People now had surgery 10 years ago, 7 years ago, they're gaining weight back again because now they have the same genetic factors that make them gain weight. And now they have bypass surgery or sleeve surgery and weight loss surgery. They don't know what to do. So because no permanent solution for this, you have to think about it. This is a chronic condition. I have to change my habits. I have to fool the body by taking different medication to help my body. The doctors have to understand it. The society has to understand it. The patient has to understand it. Then we are successful dealing with it. But if we always deal with it as a cosmetic issue and a personal choice and a behavior all the time, then unfortunately we're not going anywhere.
Yes. Um, that's very true. So at the end, I would like to ask a bit about endocrinology. And as match season is around the corner for the US residency match, how did you choose endocrinology as a profession? And what would be your word of advice for the future applicants, like who are trying to match into the US?
So for me, endocrinology was a choice because I came up from a village in Syria that has a lot of thyroid. We have iodine. We're up there in the mountain. I remember my parents and everybody in my village had thyroid issues, and there was no endocrinologist to take care of them, all of them having surgery. So from that time, I thought, oh my God, I think this will be a specialty. And then once you in it, you find it a lot more interesting than just a thyroid and diabetes. Um, I will advise applicants, other than the scores and studying, you have to work on making your resume interesting. Volunteering, camp work, research work. If I'm a program director, for example, and I'm not, and I'm getting 1,000 applicants and they all have good scores, I have to pick the most interesting. So somebody have more volunteers in a refugee camp. Somebody has volunteers and end up with a weight loss program in their community. So do something that make you stand out in the crowd. So, and people look at that and say, that person looks different, interesting. Let me interview this person. So other than again, the scores where people tell you to examine the scores, again, doing something different to make you stand out becomes really important.
Thank you so much, Dr. Al-Zuhaili, for giving us your precious time and talking on such an important subject such as diabetes. At the end, would you like to give some advice to all of the diabetics out there and some hope to people who have been like newly diagnosed with diabetes, some research which is going on, which is going to help them in the future, or like any word of advice for the newly diagnosed ones?
So again, thank you very much for having me. It is very important that if you just got diabetes, it can be reversed. The new drugs we have to diabetes now are way, 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 way better than we ever had drugs in the past. It's funny that as soon as somebody's get diagnosed with diabetes, at least from I know my friends in the Middle East, the first thing they call, oh, can I get a pancreas? Can I get a beta cell transplant? Don't put your hopes in these things. There's only 0.11111% of people of all diabetics in the world who may have a transplant or beta cell or stem cell research and all of that here. For the billion other diabetic, you can't get that. So don't put your hopes in there. Start chasing these dreams and a final cure. And also don't get these dreams and delusions that there's somebody hiding in a mountain and has the cure for all diseases, but he's refusing to give it to the world. That's we all believe in this conspiracy theory. I mean, it doesn't. These beliefs don't get you anywhere. You got to look at it. I got a disease that is reversible. I just have to change. I have to get educated, know what to do about it. Follow the millions of people who actually reverse it completely. So it's not that sentence. You can do it. Get educated. Don't get bad information and go. Don't get false hopes.
Thank you so much for your time, Dr. Al-Zuhaili.
Thank you very much. Thank you, Omar.
Thank you.
Have a good one.
Yeah.
Bye.